Welcome to the Searchlight Institute. I'm Tré Easton, and we're talking with David Bowen, our senior fellow for healthcare policy. Welcome, David.
Hi, it's a pleasure to be here.
It's
Pleasure to talk about this.
it's great to finally get this work out into the world.
Yes.
I'm really excited. A big piece of this is free primary care
Yep.
for everyone, and a competitive public option for
Yep.
individuals. Can you talk a little bit about why we arrived at those big tenets of this part of the policy?
Yeah, I think it's important for people to see real differences in their lives immediately about from policy change. Yes, there are things that, especially in healthcare, take a while to materialize, but we should also make sure that people see a real difference. And there's no more tangible of a difference than not having to pay a bill when you go in to see the doctor for a routine piece of basic primary care. We started that trend in the Affordable Care Act, where we made sure that it was free at the point of service to have vaccines and other needed preventive services. And now we're simply extending that policy to something else that's crucial. I mean, every single piece of health policy literature, public health literature, shows the value of primary care, and yet costs can be a barrier. So let's just remove that. Let's just make sure people can get the primary care that they need in a way that's very tangible to them.
Yeah, we talk a lot about trying to improve the availability of
Yeah.
healthcare and ensuring that individuals can get it when they need it because, to your point, usually seeing a primary care physician is what prevents even more sort of costly things down the road.
Absolutely.
So it was really important for us to put that out there. And, pairing that with a competitive public option was also critical.
Yeah.
I think this has sort of been in the zeitgeist around healthcare policy for a long time, even since the ACA came to be born. There were conversations around a public option around the ACA when it was
Yes, of
passed. So
course.
how do we get from there in 2009 and 2010 to the public option sort of falling out of the final version to what we're talking about now, which is a competitive public option for every American?
Yeah, I mean, what we've seen in the intervening years is that the structure of the Affordable Care Act works, where states act responsibly. The basic structure was supposed to be an expansion of Medicaid, on top of which the marketplaces, the exchanges sat. But people are really fed up with only having private plans to choose from in terms of administering their health care. And this simply says, look, we're going to provide a different option. We're going to charter a nonprofit option that's going to be different from the for-profit options. It's going to work through the same structures. It's going to be very familiar to people, but it will not have a profit motive. It will have a very different structure, and hopefully it will provide an even more affordable, even more consumer-friendly option for people who choose it. We're not taking away choice. We're not forcing people into this. We are reviving, to some extent, the structure that we proposed originally in the ACA, and giving people a nonprofit option that will be available to them, that will provide hopefully a better choice for a lot of people.
Yeah. A big thing that we hear about in these healthcare policy debates and discussions is people's frustration that their healthcare is tied to their employment.
Yeah.
Can you talk a little bit about how our plan would address that kind of concern?
Yeah, I mean, America is the only country that really structures healthcare that way. If we had a longer interview, there's a whole story about how that arose from World War II. But we have that system, and for lots and lots of people, it works. They have insurance that they are okay with, at least through their jobs. But increasingly, we're seeing jobs that are non-standard. People have multiple different jobs at the same time. People have gig jobs all along the income spectrum. So for people at lower ends of the spectrum, we have of the income ladder, we have better and more responsive ways to make sure that they can be enrolled in Medicaid. So it doesn't switch on and switch off as their income falls and rises over the course of the year. But for people who are employed in I don't even want to call it non-traditional ways because it's become so standard,
Right.
but employed with a sort of a mosaic of a job structure, that's really what the exchanges were designed to do. It's designed to give people an opportunity to have healthcare coverage in a way that's not job locked, but also takes away what was. It's easy to forget because people sort of internalized that this is the way that insurance should work. But it
Right.
used to be that if you'd ever gotten sick, you might not get insured. we took away that ability to rule out people because of pre-existing conditions.
Right.
We gave the ACA gave an opportunity to find coverage options, and now we're saying again, sort of coming back to a theme, we're taking the next logical step. Instead of saying simply, "Oh, you just have a bunch of private plans," which do work for some people, we're also going to provide a real public option.
Right.
It's another choice. It may be for many people a better choice, but it's always a choice.
Right. So much of this plan is thinking about building on the Affordable Care Act.
Yeah.
And obviously you were, I keep saying, a key architect of the Affordable Care Act. But I think what gets lost in this conversation is that it wasn't supposed to be the last conversation around healthcare policy. Even President Obama at the time of signing the legislation into law talked about sort of this being a first big step. What do you think gets lost in sort of the mythos or the sort of the things around the Affordable Care Act that people don't really understand in today's conversation?
Well, it always was and is, and all policy, almost all policy, is a stepping stone to the next policy. We joke with other members of the former Kennedy staff that if he'd been around, he probably would have given us like a weekend. Maybe it was a big bill, maybe a week off, and then it would have been back to work on making sure it was implemented right, making sure that we progressed from there. Everything is always a work in progress. We took certain steps with the ACA, I think very important steps. They had significant impacts, but certainly that's not the end of the story. There's so much left to be done. People are deeply unhappy with many aspects of healthcare, how much of a hassle it is, what my colleague Miranda Yaver calls rationing by inconvenience, just making healthcare so difficult for people. People feel quite rightly that sometimes the rules are stacked against them, whether it's a monopoly of a hospital system sort of jacking up prices in their community,
Right.
insurance companies that are unresponsive, costs that are rising, drugs that are priced out of their reach. Things really need to be done, and I'm really glad to be able to be part of an effort to build from the foundation that we laid with the ACA and really take some, hopefully, additional major steps.
Right. Many times when people say something is free, there's an asterisk at the end of that statement. So can you talk about how our free primary care plan is actually free and how that would structurally look for people?
Yeah, it's free at the point of care. People, you don't have to download an app later. You don't have to submit a bunch of forms later. You don't have to hassle with someone to get reimbursed. It is, in the same way that preventive services and vaccines work, it is free at the point of care. We also, in coming weeks, are going to be describing some very significant measures that we have to keep costs down, so that the goal here and the reality is that we're going to help people afford healthcare and make it more available and more comprehensive.
Yeah. So much of the debate in healthcare policy is dominated by people who say we have to go all the way to Medicare for all versus people who say, we should just do a public option and that's enough. I think our plan takes a little bit of conversation and sort of bits of both of that argument and say, actually, we can advance the cause of healthcare policy without kind of having to hew to these extremes. Do you agree with that?
Yeah, I think there's often a dynamic presented in the debate that you're either for Medicare for all, you're for quarter measures, not even half measures, you're for doing something really minimal. I hope that one thing that our set of proposals do is say, no, that's actually a false choice.
Yeah.
You can build from the current structure, but you can do something that really makes a difference. Makes a difference for people who don't have coverage, makes a difference for people who do have coverage, makes a difference for people who have a hard time affording the medicines they need, makes a difference for employers to make things simpler for them and give them better options for their employees. Right. So I think it's not the right choice to say, it's Medicare for all or something that's not worth doing. I really respect and admire the people who are for the Medicare for all idea. When I was on the Senate staff, I spent many hours with Senator Sanders. He is a deeply impassioned proponent of that. But it is a very significant change from what we have now. And if we're going to have a discussion about Medicare for all, let's have an eyes open Medicare for all discussion, talking about the disruption, talking about the cost shifting. And then, let's have that debate.
Right. In addition to free primary care for all and a competitive public option, our plan makes some changes to Medicaid that hopefully rights some of the wrongs from the current administration. Can you talk a little bit about that?
Yeah, I mean, Medicaid can be for so many people such a nightmare to enroll in, often by design. Again, rationing by inconvenience in a different way. Requiring elements that need secure internet connection all the time when people may not have that. Not taking into account the reality of today's workforce that someone who's a construction worker may make a whole lot more money in the summer than they do in the winter. Someone who is a gig worker may make more money in one month than the next month. We should really flip the script on Medicaid from being some, oh my gosh, it's a welfare program for poor people too. It's a part of healthcare.
Right.
People should get healthcare. And so instead of figuring out barriers, erecting barriers to people getting the healthcare that they need and that they deserve, we should make it straightforward. We should make it simple. We should also guard against fraud and abuse, and that's why our proposal includes significant expansions in the program enforcement budgets, because that's actually one of the things that really nets a lot of savings. There are people out there who've made billions of dollars on fraudulent Medicare claims, and that needs to be policed. But for people in need, for people who have real healthcare needs, administration shouldn't be a barrier. It should be a conduit to care. And we reverse the trends of recent years of just saying, oh no, we're going to penalize people who need Medicaid.
Yeah. So for people on Medicare,
Yeah.
and how could you talk about how introducing free primary care and competitive public options would affect those individuals?
Yeah. So first of all, expanding all the things we do expand to all of the different ways that people get coverage. So free primary care extends to Medicare as well, and so that makes a difference. We had that. We had the Welcome to Medicare exam, for example, that we put in, and now there's an expansion of that policy through to basic primary care. Ultimately, as what we're calling the American Health Gateway, the nonprofit public plan gets up and running, let's expand it to Medicare Advantage. Let's make sure it's a competitor not only on the exchanges but ultimately in the Medicare Advantage world as well. And the private plans say all the time that they're competitive. Well, let's have that competition.
Yeah. So one of my favorite aspects of our plan that is, again, geared towards making healthcare more available is what we do for what we kind of call modern or 21st century families. Can you talk a little bit about that?
Yes. Again, I'll pull out my broken record once again and say we're building on the structure of the ACA. The ACA allowed young adult kids to stay on their parents' plans, which really hit a gap that young adults were falling off coverage because they couldn't afford it on their own and the options were really poor. So the ACA said, okay, well, here's an option for you. But of course, as we all know, families are complex. We may have a cousin or an aunt or someone who's been part of our lives who isn't related by blood. All of those sorts of things are part of our definition of family. And so what this policy says is that just as you can enroll other family members in your coverage, so too you can enroll this broadened definition of family, not in an unlimited way, not with a free tap, but you can, in fact, if you have coverage as an individual, you can enroll an additional person in your coverage. They will pay, but at least it gives them a really strong substantive way to get coverage. If you have more than one person, you get to add on as many people as are otherwise covered. I know employers will say this is not workable, but they say a lot of things aren't workable, and then they find a way to work them out.
Right. So envision policymakers,
Yeah.
Encountering this plan that says we're going to make primary care free for everyone, and we're going to provide a competitive public option. What do you think they should prioritize in trying to get this across the finish line? And are there elements of it that are easier to push across the finish line than others, or is it also sort of in one big package?
I think there will be. Policymakers will make the choice about those things that they think are most worthwhile for their constituents based on their interests, and that is obviously their prerogative.
Right.
What we want to do is provide options in several different areas. It's not just about making coverage more available. It's not just about making coverage more affordable or care more affordable. It's not just about any one thing. There's a totality of problems that people face: affordability, difficulty, healthcare being a hassle, not being able to get it. Let's try and address all of those. Let's produce some interesting ideas in all of those areas, and then let's have that discussion. There are lots of other people who have good ideas. There's
Right.
tons of good health experts.
But ours are the best, right?
Yeah. Fortunately, we got everything right. But let's engage with all of them. I would say that there is an interlocking nature to all of this. That it's not enough just to sort of make coverage more available. You also have to make it more affordable. I think it's also important to address some of the abuses in healthcare from monopolies and private equity and other things that don't add value to healthcare and just make life harder for people. So let's look at all of those things. What exactly ends up in a final package from all of those? Obviously, we have some time to work that through.
Right.
Hopefully, all of it.
Do you think that, this policy or just healthcare policy generally right now, do you think that there is potential for bipartisan cooperation on it?
I think good ideas should always attract people. Whether they do or don't remains to be seen. But I think our job is to come up with good ideas and see where the force of, there's such a force of people wanting change that there will be a pressure to be supportive of something that will bring real change for real people.
Yeah.
Who that attracts, in what numbers, in what constellation, hard to know.
Right. Well, I'd be remiss if I didn't ask you about working with Senator Ted Kennedy while I have you. And I guess I just, want to know about the most difficult aspect of putting the Affordable Care Act together and getting it actually to a point where Congress passed it.
Other than working 18 hours a day for 2 years, that was pretty sleep deprivation. I got to know the vending machines down in the basement of Hart really well, and you'd get sad when the various awful choices were out.
Yeah.
It was tremendously difficult. It was physically demanding. There was a lot of pressure, but you kept remembering that you weren't doing this for you. You were doing this because you happened to be in the place where you could make a difference for people's lives, and I felt that. I think probably the most difficult thing is. I tell a story like, I would be working away, working hard, and then I just want to go out, get a cup of coffee and I just want a little tiny mental break. You go and get a cup of coffee, and then someone would tap you on the shoulder and say, I hope you know that Senator Kennedy's legacy, the hopes of millions of people are riding on what you're doing. I'm I just
thank you so
wanted
much.
5 minutes off. But yes, I do remember that. But what an incredible, what a pressure, but what I felt like there are so many people who are so talented who could have been in this position. I can't mess it up for them, and that's I have to do the best job that I possibly can. And I really kind of shut out all of the news media and all of everything else because I couldn't change that. All I could do was do the things that I needed to do that day, whether it's drafting a piece of statute or working with CBO or meeting with stakeholders or meeting with other offices. That's what I had to do. And then the next day I did the next thing. And it had so many near-death experiences.
Yeah.
It hung by a thread multiple times. And fortunately, it survived and continues to survive and has now become sort of the new baseline, which I think is, it also creates that responsibility to build from that baseline.
Yeah. You have repeatedly told me that Senator Kennedy's instruction to you on getting the ACA drafted was get me the most progressive bill that can get signed into law.
Yes.
And I think that's a really specific framing of sort of the task here. I guess, it's impossible to channel the man, but what do you think his opinion of providing free primary care for every individual and a competitive public option would be in the sort of the terms of that kind of progressive goal?
Oh, he'd love it, but he'd be talking about, okay, now we need to talk to so and so. Now we need to talk to so and you got to make sure. Geez, you got to make sure that these guys. So he was not only had the principles of what he was for, but he also had a great sense of the dynamic. he said that when he, toward the end of his service, I mean, he was not able to be in the Senate as much as he wanted. And he said to our staff director that he missed feeling the chemistry and the physicality of the cloakroom, right? Where the senators are together and you could get a sense of the room.
Right.
And he was as good as anyone really has ever been in reading that sense of the room. And I think that he would love this. He would love the chat. He'd love doing it the first time. He would love to do it again.
Yeah.
I think that he would be, I think one of his proudest moments, had he been able to be there, would have been the passage of the ACA.
Yeah.
And being so proud of his colleagues. And, there are a finite number of opportunities you get for particular issues. And I just my own sense of it and looking at some polling, healthcare is rising again as a major, major frustration for people.
Right.
And there's a need for action. And I think our role can be to provide some good ideas for what that action might look like.
Right. Final question.
Yeah.
President Obama referred to the ACA as a starter home, I believe. So, talk about how our policy of providing free primary care and a competitive public option builds upon that starter home.
Yeah, I mean, it takes the structure and expands outward, as will some of the other things that we're going to be describing in the coming weeks. It says, okay, well, ACA had free preventive care. Well, we're going to expand that. We're going to expand that small starter home kitchen to something more comprehensive by adding in primary care. We're going to take and by the way, people will say that it's going to be a hugely costly thing. We've done analyses. It's, it is not a budget buster, certainly when paired with the cost control measures that we have, or cost containment measures that we have. We think this is responsible.
Right.
But it expands that policy. The public option, the American Health Gateway, takes the existing structure and gives another option within it, a truly public option. So these are all ways that we're expanding from the basic structure into something that is in the same direction, but expands it out in a logical way.
Great. Right.
Oh, and I should also add, the expanded definition of families takes the kids stay on your plan provision and expands that as well. But again, the theme is working from the same structure, not tearing down the house and building a new one with all the challenges that can bring, but building from what we have in a way that will make a difference in people's lives, we hope.
I think that's a great point to end on. This has
Thank
been
you.
Talk Time with Tré.